Today we've got Dr. Tod Wyn coming to present to us on the topic of nausea and vomiting. He owns the distinction of first fellow through the program, and I don't think people will ever forget that. So that'll keep coming up. I think that's higher honors than his medical degree sometimes. But he worked ER.
Right place at the right time.
Exactly. So worked ER, we were just talking about it, 15 years or so before. 17. Before doing the HPM fellowship. So now he is medical director over at Hospice of Holland and Keystone. So I'm going to turn it over to him to get started.
Thank you, Joel. Good morning, everybody. I can't see who's on with us, so I'll assume people are there. And I'll also assume that you have the ability to ask questions. I certainly welcome questions throughout the presentation. We'll have some time at the end as well, but and I also am sure that we have a chat feature.
Yep, I'm watching the chat here.
So Joel will be on target for that. So this is a lecture I've been giving for a long time now. This is actually a lecture I put together during my fellowship. And the idea here is to kind of give a general overview of we'll get to the objectives actually. So where is this going here? So
do you want to put it in slideshow mode?
This works, I think. So my objectives today are to identify the mechanisms involved in nausea and the different triggers that will induce nausea and vomiting. And then we can talk about the different treatments and remedies and why they kind of fit where they do and patient selection with those patients. So some different quotes. This is always one I like, which is just the nausea and vomiting is the great equalizer. So one of the best temporary cures for pride and affectation is seasickness. A man who wants to vomit never puts on airs. And for all of us have been in that situation. There is no arrogance in vomiting. And then Mary Roach had this one, that the act of vomiting deserves your respect. It's an orchestral event of the gut. And we will actually explore that a little bit because there is such an interesting number of different pathways that are in the whole issue of nausea, of triggering vomiting, that it really does sometimes feel like an orchestra. And then, of course, got to get Rodney Dangerfield in here. So he went to see his doctor and told him, yeah, every morning when I get up and look in the mirror, I feel like throwing up. What's wrong with me? And then my doctor says, I don't know, but your eyesight's perfect. So, all right. Vomiting in politics. We see it so here's oh dear. Yeah. So this is George Bush with the Japanese prime minister in that rather infamous scene where he, as president of the United States, still had to throw up. And this is one of our great soccer players, the overexertion. We see this in tennis. We see this in any sport where that act of overexertion can sometimes result in nausea and vomiting. We see it in pop culture. This is Britney Spears and somebody else I should know at this point, but I can't remember. But we see it on stage in music productions. And this is from Stand By Me. So just this is this kind of this group vomiting phenomenon where this scene in the movie you see this boy vomiting on somebody, and then as the camera pans through the stadium, the various people all start vomiting in unison, just in sympathy. And then vomiting in October. So usually I give this lecture in October. Today it's in August. And I forgot to update this particular slide. So I'm not sure what sort of theme we could have for vomiting in August, other than perhaps heat stroke or something like that, I suppose. But we certainly get treated to some interesting jack-o'-lanterns during the month of September. Historical remedies. So back in the day, they used to think that bloodletting helped with everything, but they also thought it would help with nausea and vomiting. And then different herbs, things like ginger and mint, and then frankincense. So that was those things were used then, and the ginger and mint are actually still in use today. We see people pop open a can of ginger ale in the hopes that will, in fact, one of my memories of my father when I was young. We were on vacation somewhere, and I was having some nausea and vomiting, and Dad popped open a Verner's, and boy, that helped make me feel a little better. So. And it has to be Verner's, by the way. It has to be Verner's. And then mint. Some people will still use mint diffusers in their rooms. just to kind of get a little of that aroma going on. So that can be helpful. I do not seem to run into the use of frankincense. So anyway. And then we have Dr. Alice Emery, my colleague, to thank for this particular joke. What's the best food to eat when you're vomiting? Bananas, because they taste the best when they're coming back on up. For the context today, and apologies for the clunkiness here with the slides, the context for our discussion today, we'll use a case study. And so back when I was doing my fellowship here at Trillium Woods, we had an 84-year-old woman come on in to stay. She was on hospice, and she had been diagnosed with ovarian cancer a few years prior. She'd undergone surgery, she'd undergone chemotherapy, and she had some diffuse abdominal peritoneal metastases, which had then contributed to a partial bowel obstruction. So she came in, she had this rather significant nausea and vomiting. She had this problems with swallowing, and then interestingly, she also had this challenge with gastroesophageal reflux disease, which had been an ongoing problem for her, in which she kind of sometimes got a little bit confused between what was heartburn and what was nausea and vomiting. And then this last sentence we'll pay attention to, because she was clear she really did want as much as possible to keep eating. So even though this woman had terminal disease, and even though she's in a hospice facility, her hope was that she could still live a bit longer. And she knew that in order to do that, she would need to keep eating. The etiology of nausea is complex. And so this slide, we'll have another slide a little bit later on that's somewhat similar to it, but this indicates some of the various pathways that can be utilized to create nausea. So on the top there, we have the chemoreceptor trigger zone. And that's a cranial one. The vestibular there on the left-hand side, for those of us who've experienced seasickness or air sickness, that's a very powerful etiology. We have the cortex there, so sometimes brain injuries, and for those of us who see patients with brain injuries or sometimes strokes, can depending on the injured area of the brain, nausea and vomiting can be a prominent one. Certainly, trauma, swelling in the brain, blood in the brain can be a triggering factor for nausea. And then you also have the GI peripheral pathways, so the guts and the different receptors that are there. Joel, can we expand the size of this slide? I'm having trouble reading it myself here.
We'll get rid of this first, then we can go to the slideshow.
There we are. That's better. Thank you.
All right. And I'm just going to minimize this too to get that out of the way for you.
Okay. Thank you.
All right.
Yeah. Okay. Thank you. And then there we go. So we'll do an assessment here. So like when we're gathering any history with a patient, we want to pay attention to, when did this begin? How often are you feeling the sensation of nausea? How often are you actually vomiting? We're going to want to query a little bit about what is the relationship to eating. Are you taking certain foods that seem to be bothersome? Are you on certain medications that are either helpful or not so helpful? What are your current antiemetics that you're taking, and how are you taking them? And are they just PRN? And if so, how often are you actually taking the PRN medications and all of this? So that should be an important part of your history gathering. You want to know, is this chronic versus progressing? What are the different alleviating factors? We're always talking about severity with pain. We can talk about severity with shortness of breath and with nausea and vomiting as well. And then we can talk, as we are very good at doing, I think, as palliative physicians and hospice physicians, is to talk very clearly about what are our goals. So when we talk with patients about chemotherapy, we can say, is the goal to cure, or is the goal not to cure, but to prolong life and hopefully alleviate symptoms? Sometimes when I'm talking with patients about pain management, I'm clear to say my goal is not to get you pain-free. That's not a likely goal. I could do it, but you'd have to be completely sedated. My goal is to get your pain to a place where it's more tolerable. We can have a similar discussion with our patients about what is an appropriate goal for their nausea and vomiting. And then it comes back to, again, this deal for this particular patient. One of her goals, as she had been clear, was that she wanted to keep eating. That's important to know because that can affect our nausea and vomiting. We're going to want to talk about potential reversible causes. So that old joke about doctor, it hurts when I do this. Well, okay, don't do that. Same thing here with nausea and vomiting. If you can identify particular drugs or different issues that are reversible, then pay attention to those. So we run into things like chemotherapy and opiate medication, certain antibiotics, NSAIDs, some of the SSRIs. These are all kind of classic for contributing for nausea in some patients. Constipation is another one. For patients who have significant constipation, you can medicate them all day long, but the biggest thing you're going to be able to do for them is relieve their constipation. Gastroparesis can be part of that. A slow-moving gut is just a real challenge. Gastroesophageal reflux disease, uremia, various infections, all are potentially reversible causes, places where you can focus some of your attention at alleviating the cause. Pain is certainly also associated with nausea. Dehydration, boy, for those of us who've been in the ER, sometimes the magic of giving people a liter of IV fluids is wonderful and just very, very effective at helping people feel a lot better. Correcting electrolyte imbalances such as hypercalcemia, endocrine dysfunctions. I mentioned earlier about increased intracranial pressure from swelling or from blood. And then anxiety. That slide before where we had the group vomiting, that seems to be more linked to our anxiety probably than anything else. Other causes, pregnancy, cyclic vomiting syndrome, often linked to the overutilization of marijuana. Various liver diseases can be part of this, classically part of migraine headaches. Certainly following surgery and anesthesia, we'll run into people who have probable post-surgical or post-anesthesia nausea. A myocardial infarction, people who come in with a heart attack, that nausea is often a part of that constellation of symptoms that we're looking for. Violent coughing, being hungover. Meniere's disease, which is more the vestibular part of this. Yeah. This is a slide similar to that other orchestral sort of slide that I showed earlier. This has a lot more words to it, but we can again see how complicated this whole process of nausea is. So we'll kind of start on the left-hand side of the screen there again. So this starts out with the vestibular system there. And so motion is a trigger for that, or labyrinthine disorders. You can then get some interaction then with the chemoreceptor trigger zone, which is at the middle of the slide there, and that's affected by numerous things, including the vestibular system and various drugs, metabolic products, bacterial infections, those kinds of things. At the bottom of the screen, we see the peripheral pathways, those that are more associated with the gut, the stomach, the bowel, and that can be sometimes mechanical. Where you're having distension of a stomach or distension of a bowel can be a very strong trigger for nausea, and then just simply irritation of the different receptors within the guts that we'll see happen as a result of chemotherapy or sometimes stretch. We'll go more towards the top of the screen. That's just kind of that again refers to the brain, the cortex, the direct insult to the brain that can be part of all of this. And then all of these different things will have an impact on the vomiting center of the brain, which is located in the medulla. And then that finally triggers the whole process of nausea and vomiting. So this slide is here less as a place to really have specific recall. I'm not looking for you to have that, but more a generalized understanding that there are, in fact, some specific places where this whole sensation of nausea is triggered, and then that also implies that there are sometimes more specific remedies that will be more effective than others. So this idea of just giving sublingual Zofran for everybody who comes in with nausea and vomiting, I think we all do that. I'm not necessarily arguing that that's a bad strategy, but we also understand why there's some reasons why it's not the most effective strategy. And we can get more precise, we can get more surgical, I guess, if we wanted to use that word for it. And then this slide, most patients have multifactorial causes. So this is that whole orchestral idea here. My son is a cellist, so I'm partial to classical symphonies. We need to talk about non-pharmacologic treatment. We'll certainly spend quite a bit of time talking about the various drugs to use, but we got to talk about non-pharmacologic treatment. So reassurance and relaxation is a huge one. We have this for pain and for shortness of breath, and it applies for nausea as well. Just that calming presence, that reassurance that we have the ability to help. John Mulder used to talk about in the process of doing that reassurance, he would oftentimes hold the patient's wrist, and while he was doing that, kind of somewhat subtly exert a little pressure on the median part of the wrist at the I'm going to forget the particular point there, but it was kind of an acupressure sort of a thing, and we'll talk about that in a little while. But you can do both at the same time, be a calming presence while also touching. We talked about correcting dehydration and electrolyte disturbances. Decompression, this is a big one when it's involved with especially when you've got a bowel obstruction going on, that again, all the medications that you want to throw at somebody are not going to be nearly as effective as the act of decompressing somebody, putting in an NG tube or sometimes a venting gastrostomy tube, correcting constipation. Oral hygiene. All of us feel better when we've brushed our teeth or done a mouth rinse. Patients who are ill oftentimes are forgoing things like brushing teeth and mouth rinses, and they're not drinking like they used to, and the mouth and the teeth and the gums and all of that can get sticky, and the act of just brushing teeth for them or having your aide help them with getting a rinse going can be a very important part of feeling better. Reducing food intake and using cold food rather than hot food can be helpful. Tube feedings. So this we run into, I think, a lot. Patients who come to us on tube feedings and they're declining. And because they're declining, their bowels are slowing down. And because that's happening, then they're just not tolerating those tube feedings as well. And now they're getting some distension in the gut. And so reducing or eliminating tube feedings is often critical in helping people feel better. Avoiding odors. I love the smell of bacon, but bacon to a person who's nauseated is not a great thing. And you don't want to be doing this. I do not know the context for that photo. I got this off the internet a long time ago. In my fantasies, this is a Russian camp where they're testing the efficacies of various deodorants, but I do not know the context.
Well, tasted urine. I feel like they're testing. Do you know what I mean?
Yeah.
What are you secreting?
Yeah. We can now talk about matching the etiology with the mechanism. So we've talked about the chemoreceptor trigger zone, the vestibular pathway, the cortex, the GI and peripheral pathways. Those are associated with various receptors, and there's a mechanism there. So the CTZ seems particularly involved with the use of dopamine 2 and 5-HT3 antagonists, whereas for the vestibular pathway, that's going to be more impacted by the use of antihistamines and antimuscarinics. For the cortex, we're looking at anxiolytics and sometimes antihistamines. And for the gut, that again is where we find the dopamine 2 antagonists and the 5-HT3 antagonists. And so we'll talk then about the various medications that reflect those different mechanisms. And that's in this slide. So we're going to match the medication to the mechanism. So examples of your dopamine 2 antagonists, these are the Haldols, the Droperidols, Reglan. John was a big fan of Reglan, but that seems to be where most of its antiemetic effect is through its dopamine antagonism. Compazine and Thorazine, these are all good examples of dopamine antagonists. The classic 5-HT3 antagonist, this is Zofran. And then there's other different examples of that, Kytrel and Amend. I don't run into those all that often, once in a while, but not very often. Remeron is actually a 5-HT3 antagonist. And of course, many of us will use Remeron not mainly as an antiemetic, but often more as an appetite stimulant, in addition to its antidepressant effects. And so Remeron can be an interesting choice too. Antihistamines, Benadryl would be your classic. Antivert is another one. I find Antivert to be less sedating. Phenergan is one. Hydroxyzine is another. We're seeing hydroxyzine being used more, of course, for anxiety as well. When you start talking about anticholinergics and antimuscarinics, this is scopolamine patches, Levsins, those types of things. Promotility drugs like Reglan and Propulsid, those have their place particularly for bowel related issues. And then kind of this wastebasket other place where I've landed things like Decadron, Ativan, and Zyprexa. And Decadron, of course, strong anti-inflammatory, Ativan, strong anxiolytic. And Zyprexa is, of course, an example of an antipsychotic that's not necessarily just through its dopamine antagonism there. So Zyprexa also has some gut stimulating features to it that make it a very nice choice in some of these areas. So that's just kind of an other place that I don't have a specific mechanism to talk about. When we're talking about opioid-induced nausea, of course, there's some picture of some poppies there on the screen. This primarily hits your chemoreceptor trigger zone. And so you can consider opioid rotation. Some people just simply are more sensitive to some opiates than another, and I don't see a good rhyme or reason to that. Morphine is known to have more toxic metabolites than some of the others, and so that is probably a problem why people have some more problems with morphine. But I have some patients who have problems with oxy or with Dilaudid, and then you just find that maybe they do actually tolerate the morphine better somehow. I don't have a good understanding of why some narcotics affect people differently than others. But opioid rotation is effective. But here again, you want to definitely talk about using dopamine antagonists. So Reglan, Haldol, Compazine, Thorazine would be your classics. Those first three commonly used. Thorazine, just not used all that often these days. My only time when I use Thorazine really is for hiccups, and you could use a lot of different things for hiccups as well. So, but those are some classic dopamine antagonists. Chemotherapy-induced nausea and vomiting, something we do run into very frequently, and this is primarily from the 5-HT3 stimulating pathways, the gut and the peripheral pathways there. And so here again, you want to think about those 5-HT3 antagonists, so Zofran, Kytril, Emend, and Remeron. A malignant bowel obstruction is something that we do run into with some regularity. Patients who have a lot of metastatic disease involving the peritoneum, people who've had prior surgeries, but you're getting this malignant bowel obstruction where your gut's getting distended and nausea and vomiting are going to ensue. That's primarily stimulating the CTZ, so you again can look at those dopamine antagonists like Reglan, Compazine, and Haldol. Octreotide is a nice medication here. Octreotide is given subcutaneously and can be helpful in decreasing the secretions that are involved there, and that seems to be of some benefit. Decadron, in this is where I find Decadron is really quite necessary. The reducing of the swelling of the gut, reducing some of the inflammatory pieces there seems to be very important. And then this last one, last but not least, decompression. Decompression just seems to be very, very important. So it's not uncommon for me to have a patient who's in the hospital who's going to be transitioning to an outpatient setting on hospice care, and we are requesting placement of a venting gastrostomy tube prior to discharge.
Do you want questions and comments now? Or
Sure,
should we go
you betcha. Go ahead.
Okay, so Gretchen just had a comment come through.
Sure.
Just to clarify, Emend is a neurokinin 1 receptor antagonist, helpful with chemo-induced nausea, often given at the time of chemo with highly emetogenic chemo regimens.
Emend is not a 5-HT3 antagonist?
Wonder if it's got dual properties.
Okay. Yeah, I mean, I'm not necessarily quibbling here. I just thought that was its primary area. But I appreciate your insights, Gretchen. So.
And it may well have both.
So say that again, if you would.
It's a neurokinin 1 receptor antagonist.
Okay.
But helpful with the chemo-induced nausea.
Yes.
So.
Yep. So I'll actually back up here a minute if I can. So the Emend, like Zofran and Kytril, these were developed more for that chemotherapy-induced nausea and vomiting regimen. The Zofran, and I'm pretty sure the Kytril are 5-HT3 antagonists. I'm afraid I thought the Emend was as well, but that may be a different mechanism that's working. But again, more useful in the setting of chemotherapy-induced nausea.
It's given it for surgery.
Given them for surgery?
I was given it like pre-op.
Yeah.
They were like, I didn't know what the drug was.
Okay. Well, and so back when Zofran came out, I was in my training and it was being utilized, but the clear understanding we had when Zofran came out was that it was really for chemotherapy induced nausea and vomiting. And then people started using it for other sorts of mechanisms, and lo and behold, it was actually quite helpful there too. I can remember in the ER, one of my colleagues giving it to a kid, and I was like, well, we're giving it to a kid, but they're not on chemo, and this kind of a thing. So it is interesting how for some of these medications, they were designed for a specific utilization, but then seem to have some expanding role. And I'm afraid I don't use Amend all that often. So thank you for the insights from
Dr.
everybody.
Levisor, it's one of his favorite, like.
Is that right?
With complex nausea.
Okay.
What's the cost? I was curious, like relative, not like actual number, just like,
Expensive.
yeah, that's what I thought.
It is expensive.
Okay.
Yeah, Kytril also.
But works well.
Well, right, all the good stuff is,
So thank you for your input there, everyone. Appreciate that. We'll then move on to motion-induced nausea, primarily from stimulation of the vestibular system. And then here you want to think your antimuscarinics, the scopolamine patches, the hyoscyamines, lessons, those kinds of things. Antihistamines like Antivert and Phenergan also can be effective. I have personally used Antivert for motion sickness, and I did find it to be less sedating than some of the others. Also a bit more helpful, but it was not quite magical for me. I'm not going out on the big lake these days anymore for salmon fishing. Too many times I've had to turn around, no matter how much Antivert and C-bands I do, it's just not going to happen. So.
Goes to Michigan and then sure it goes on.
No carnival rides either, no. Increased intracranial pressure from a variety of different challenges there. Directly stimulates the vomiting center, and you want to make sure to try to decrease the pressure. So steroids can actually be a very important part of that. We've got a lot of patients who come to us with brain masses that are causing increased pressure, and they'll be on steroids, sometimes very high dose steroids. Antihistamines can be helpful. But again, most patients have multifactorial causes. So that's probably where I land most of the time when I say, why does Zofran work when it was designed to be an anti-chemo nausea drug? Well, it's because it gets complicated. Life is messy, and so is the process of nausea and vomiting. Dosing. Well, I'm an old ER doc, so we used to like this phrase, whether we're talking about cardioverting somebody or whether we're talking about medications, go hard or go home. But that certainly applies here. So when we have those challenging patients, and let's face it, by the time they get to us, they're often challenging. So we want to do appropriate doses, and we want to do them scheduled around the clock. So it's fine to start out PRN, and it's fine to start out with a little Zofran. But as you're starting to get into those more complicated, these more calcitrant areas, you're going to want to make sure you're doing good doses. And rather than just doing it PRN, I definitely recommend getting it scheduled around the clock and coming up then with if you need to, with a multi-dose regimen to help hit the various etiologies. So we'll go back to our case study. Remember, is this 84-year-old woman with the ovarian cancer who wanted to keep eating, and she had a lot of complicated complaints. So we put her on Reglan. Again, I just remember John I hadn't used a lot of Reglan in my life at that point. I'd used it on occasion, but not like that. And so John was a big fan of Reglan. So we got some Reglan going. We got some Zofran, of course, going. And then because of her complaints of the gastroesophageal reflux disease, we also used a PPI, proton pump inhibitor. And initially, she seemed to have some improvement with that, but then she had some worsening nausea. Didn't really have much in the way of actual vomiting, and it was just kind of frustrating because she would have this confusion between, am I nauseated or am I having heartburn? And for her, just those two symptoms were difficult to kind of parse out which was which. So we added some Phenergan and we added an H2 blocker, but no real improvement with that. And so now we are faced with intractable vomiting. We've done appropriate doses. We've done scheduled things around the clock. We're hitting it with various types of mechanisms, and yet still this patient is just miserable. So now we can talk about polydrug regimens and some different routes of delivery for those. General guidelines, like with pain management, I tend to not want to use more than one drug from each class. So if I'm going to use an opiate, good. And if I'm going to use a fast-acting opiate plus a long-acting opiate, good. But I don't use two fast-acting narcotics, and I don't use two long-acting narcotics. And I tend to then, if we're going to go from narcotics, then you want to start to use a gabapentinoid, or you might want to use a muscle relaxer or an anti-inflammatory. Similarly, here, as we're approaching the world of trying to manage somebody with intractable vomiting, I recommend not using more than one drug from each class, but starting to use drugs from different classes to hit those various pathways. Less traditional medications, coming back to that other category that I had on a previous slide, Decadron, Ativan, and Zyprexa. These are very nice medications to bring into the mix at this point. And you could start to consider alternate routes. So for our patients who are vomiting, one of the big challenges is actually getting the medication in them. And so sometimes you can do this through subcutaneous infusions. You can do it rectally. And historically, you could do it topically. And we'll talk a little bit about that because that's pretty much fallen out of favor these days. The different topical remedies, which everybody used to kind of swear by, have just been shown to be not effective. We can be alert for drug interactions. Continuous infusions have the potential to provide very quick and effective relief of intractable nausea. One of the nice things I've been able to say to patients when we get to this time is that this is sometimes feels like some of the closest stuff that I'll do to magic, starting these continuous infusions. They can at some point be transitioned over to an oral regimen. And a typical one is called a BAD infusion. That's Benadryl, Ativan, and Decadron, run as a continuous infusion. And I've included the recipe for that here. That recipe, by the way, is just kind of a guideline. It can be utilized in different ways depending on your different hospital systems. So back when I joined Hospice of Holland and was trying to get this going at Holland Hospital, we ended up settling on a little bit of a different recipe based on some of their different pumps and all of that. But this is kind of a nice place to get started. So this is Benadryl, Ativan, and Decadron. At this point in the lecture, when I would give it historically, John would invariably tell a story about getting this going at Butterworth when he was kind of new and he was starting to get this into the system. And so one of his very first patients that he put on a BAD infusion, and first of all, the hospital refused to call it a BAD infusion for obvious reasons, but one of his very first patients died fairly soon after starting this infusion. And there was a great deal of hubbub that they had, that perhaps the patient had died, not just because of the infusion, but specifically due to the Ativan. And so they ended up digging into this further and investigating, and they found that actually, because of the type of tubing that they were using, this patient had not received any Ativan. And so that was kind of reassuring, I think, for everybody. But even just doing the whole calculation, that the Ativan in this dose is still very small. We are not at risk of overdosing our patients. But it can be, it's a new thing yet for a lot of different people. It's probably new for our fellows, but it can be a very effective infusion to use. And it can be done in hospice patients. It can be done as a subcutaneous infusion. So I'll do these in the homes. I've done them occasionally in assisted living facilities. Much more difficult to do them in long-term care facilities, but doing them in home and in assisted living facilities is certainly possible.
And couldn't that patient at Butterworth also be that double effect thing? Like if they'd gotten all the meds and finally weren't miserable,
Right.
maybe they died.
Right.
Like,
Yeah. An alternate infusion is a Reglan, Benadryl, and Decadron infusion. So this got rid of the Ativan, in part, I think, just trying to help placate the anxieties of people. I don't typically use this one very often in my practice. I use the BAD infusion with our hospice patients with some regularity. Now, again, not super frequent, but with some regularity there. And again, I've included the recipe for that for those of you who are interested. So. Also, I've kind of wondered about, we could tweak, as palliative and hospice, we always want to tweak things. I had the privilege of being here a little earlier today, and I was listening to our anesthesiologist fellow talk about tweaking different blocks and using different types of catheters. So we always tweak things, but I've wondered about using a Haldol Ativan Decadron or a Reglan Ativan Decadron. I mean, we could get crazy with it. I will point out that the common active ingredient here seems to be the Decadron. And who am I thinking of? My apologies if I'm going to blank on his name. He did his fellowship at Ohio State University.
Oh, yes,
Mike
Dr. Johnson.
Johnson.
Yeah,
Bob Johnson.
Johnson.
Sorry, Bob. If you're on the line, sorry, Bob. So Bob did his fellowship at Ohio State University, and he kind of did dig into some of this here, and he really came away quite convinced that the steroid was really the main active player in providing relief for our patients. That's nice to know because we use steroids all the time. We can give steroids in a variety of different ways, and that's helpful. We should talk for a little bit about alternative therapies. Acupuncture, acupressure, Korean hand therapy, aromatherapy. These are all areas that I still kind of qualify them as alternative therapies, but they have value. They have a lot of history behind them. And for many of our patients, they have some efficacy that we cannot achieve in other ways. So I'll start at the bottom. Aromatherapy, I referenced kind of at the beginning of the lecture. It's very easy for patients to have a little mint or some kind of nice aroma going on around them. Nothing overpowering, but something in the background like some mint can be a nice choice for them. Easy to do, side effect free, and kind of that holistic way of approaching patients that we are very fond of. I think we'll get into here some acupuncture. So this is just a slide that references the 5 phases theory of acupuncture. I am not at all knowledgeable about acupuncture, but I'll just leave that there for a second. Yeah. We have had different practitioners of acupuncture within the community. We do still. And for those patients who are interested, I think to have them explore this is also a very reasonable thing to do. This is generally believed to be more helpful in the setting of chemotherapy and postoperative nausea. Acupressure, so this is that pressure point, that P6 pressure point that I was alluding to again, that Dr. Mulder used to do when he would sit with patients and just kind of put a little pressure over that median area of the wrist. C-bands also probably work in this way, providing some compression of that area. Korean hand therapy. So there's this theory that you can stimulate various parts of the body and different systems within the body through different pressure points and stimulation of various points of the hand. And then aromatherapy. Ginger, peppermint, lavender. Lavender is a nice one. Yep. Fennel seed oil, lemon oil. These are all kind of some nice different choices that you can have, and they're easy to find and easy to utilize. And again, really low in terms of low, very few side effects, no real downside to doing them.
There's a little extra anxiety in the room. I know that helps
Yeah.
the whole family.
Sure, you betcha.
The Ativan.
The whole room.
Yeah, right. I could put Ativan in there too.
No, I'm like,
We'll spend a little time talking about marijuana. And again, what I can say about this is that I am not knowledgeable about marijuana. What I certainly have seen over the course of the last couple of decades is a growing acceptance of the utilization of marijuana for this. When I give, well, I'll just go ahead and go through the slide here a minute. So it seems to have demonstrated effectiveness in nausea and vomiting. It certainly can seem to stimulate hunger for people. Has some analgesic properties, seems to have some help with, at least temporarily, lowering intraocular pressure. People with multiple sclerosis may have some additional benefit from it. Depression, these are much more questionable, and the amount of research that's out on these areas, I should say the amount of good quality research remains lean. So we don't have a lot to go on there, but we do have some increased acceptance that there's probably some help with nausea, vomiting, appetite stimulation, and analgesia. The mechanism is unclear, probably involves some inhibition of the vomiting center when it comes to the nausea, vomiting. It does have an extensive first pass hepatic metabolism. Administration and dosing. So it's hard as a physician to get behind anybody smoking it. They're still getting exposure to carbon monoxide, still getting exposure to tar. You're going to get a peak in a short period of time, but then decline fairly quickly. It's hard to see a lot of value in smoking it. Vaping, no elevation of the carbon monoxide or tar, more predictable, but there has been some association with some pulmonary issues for people who have vaped this stuff. So hard for me to get behind that. Ingesting is clearly the most common way patients, at least my patients, will utilize marijuana. They'll take it in some sort of an oral form through some sort of a vehicle, whether it's a brownie or a pretzel or a gummy or something along those lines. In this way, it still can produce a psychoactive metabolite, so patients need to be aware of that. But I think that there are ways to kind of protect against that. And I have never seen anybody recommend a marijuana suppository, but I'll be bringing it here if I ever do. Before we leave this, then I'll just say that in general, when I'm talking to patients about marijuana, I'm careful to tell them that number one, I'm not that knowledgeable about it, and that I'm not necessarily really pushing it, but I will be clear with them that I'm open to it. I will usually ask my patients, if they are interested in doing it, have they ever done marijuana before recreationally? And did they have a good response or not such a good response? Because if they've used it recreationally before and they liked it, well, chances are they're going to kind of like it again here now. If they've used it before and didn't do so well with it, well, then I'm a little more skeptical that it's going to be the right thing for them. And then I'm usually recommending that they not get this from their family member, that they not get this from somebody off the street, but that they actually go to a dispensary and talk to somebody there who does have some opinion that's perhaps more grounded in some experience than mine would be. And that opinion can be valuable in terms of what plant to use. What are you actually looking for? Are you looking for more for analgesic properties? Are you looking at more for anti-nausea properties, this kind of a thing? So to be talking to the people at the dispensary about what your goals are with it, and to let them give you some advice. The other thing about going to a dispensary is that you're going to have some consistency in terms of the actual plant that's being used. You're going to have some consistency in terms of the recipe. So if they're giving you a pretzel, you can have some confidence that that pretzel's going through the usual process with the usual plant. You're going to have that consistency, hopefully, of dosing, so you can really be able to ascertain and discern, is this medication, is this helping me or not helping me? And then to move on in some sort of an orderly way from that. So that's my typical advice on marijuana. There are marijuana-ish things that we can talk about. So for instance, synthetic forms of THC. And this is, we're talking about Marinol, which is a Schedule III drug. And then there's other versions of this as well. So in Canada, there's one called Casamet and Sativex, which is a mouth spray that some of the patients with multiple sclerosis will utilize. Before I come back, leave that slide. So Marinol is kind of an interesting one. What I've liked about Marinol is that you can use it in the hospital setting. And I have used it in the hospital setting. And so on a couple of occasions, it's been really quite nice. So I had two patients very close to each other. They were at Mary Freebed, and they were both having problems with challenging headaches from various initial causes. But for both of them, they confessed to a history of using marijuana quite a lot. Their daily use was extensive. And obviously, we weren't able to do that in the hospital. And so I had said, well, I have some sort of a substitute. We can do Marinol. And so we got Marinol going on both of these guys, and both of these guys had a very nice response to it. They felt a lot better. Thank you, Dr. Wyn, for doing this. And I found myself wondering, did I do anything for them with this Marinol based on what they were using before? Or was it just more the fact that I listened to them and talked with them and offered them some sort of an option to try to help meet their need, that may have had more positive benefit than the actual drug itself. But I was impressed with it. And I have subsequently used it with patients for nausea in the hospital setting. It's good. I think there's a couple of challenges with using it as an outpatient. The first one is it's expensive, and insurance companies hate paying for it. Prior authorizations for me have seldom worked on Marinol. Maybe those of you who are listening in have had better success with that than I have, but I have not had much success with getting prior authorizations for utilizing Marinol. And then the other thing is, I guess in general, this is a processed drug, And I am of the opinion that probably the active plant is probably a better choice for them in terms of its clinical efficacy. So if patients have a positive response to Marinol in the hospital and they want to do something similar as an outpatient, I'm usually recommending that consider going to a dispensary and just kind of doing it that way rather than trying to deal with the actual Marinol. In others, I'm open to whatever experiences the rest of the group has here.
Do you think they were having kind of a withdrawal phenomenon from the heavy
Yes,
usage?
yes. I was wondering more about a
Yeah,
withdrawal
like-
phenomenon for them than anything.
Like, as opposed to giving a naive person,
Right.
may not get much of a response.
Right.
But since they were,
Yep.
Not first line headache management.
well, yeah, but I mean, like, headache more from discontinuation.
I think withdrawal from marijuana is a real thing.
Yeah, I mean, especially these
Yep.
like heavy hitters that.
Yep. So
Comment too, Rick Simpson oil is another option.
Rick Simpson oil, sure. Yeah, I do not know much about that at all.
What is it?
It's, I believe, is it topical? I've only heard of it myself.
I think it's a topical THC-ish, isn't it?
Rick Simpson oil.
Who?
Kiva, can you tell us, is it more of a topical sort of administration you're using it for? All right.
Okay. Well, I'll wait for her response.
Used topically and orally with some recipes.
Okay.
Is it like a compounded or like, I mean, it's not a
It's commercial.
pharmaceutical, commercial, yeah, like from Harvest Health or something.
So final thoughts on marijuana. Good research remains difficult, but is getting better. I think the specific plant dosing and administration probably does matter. There are still some side effects, drug interactions. I mentioned withdrawal earlier. Those most likely to benefit are those who have not responded to other more traditional interventions. And those least likely to benefit are the elderly with no prior experience. So very common for us to have the grandmothers whose grandchildren are saying, "Oh, grandma, this will cure your cancer." And I think we need to view that with some skepticism. And positive thoughts matter, as with everything. So for our conclusion, patient was placed on a subcutaneous bad drip, which we gradually increased. We continued her H2 blocker and her PPI, but we also gave her GI cocktail. That old standby in the emergency department was helpful for her GERD. And she responded well and had nearly complete resolution of both the nausea, vomiting, and her GERD. And then she gradually declined, and then she passed away comfortably.
Was she someone who was considered for decompression from, because you
It
said.
was a partial bowel obstruction, and she didn't seem to need that. So random thoughts, Decadron is a great antiemetic. Haldol and Zyprexa are as well. Decompression may be necessary. Again, reminder to use combination drugs of different mechanisms, and anticipatory dosing is beneficial, that scheduled dosing. Successful strategies, identify the most likely etiology and mechanism involved. Choose the medication based on that mechanism. Dose appropriately on a scheduled basis. If ineffective, start to look at multi-drug regimens. Consider continuous infusions. Consider less traditional interventions and medications. That concludes. So we got a few minutes left over for questions.
I'll stop sharing his.
I'll let you do that, my friend.
When do you use the PPI? I mean, like always, or is it, what is it supposed to help with? Is it like if you're using Decadron or what? I mean, or is it just?
So I really don't approach a PPI for nausea unless I'm really convinced that the reflux is part of it. I mentioned that with her just because she was complicated in terms of trying to ascertain what was her main symptom that she was actually complaining of. But I don't use PPIs routinely for the treatment of nausea and vomiting. I will use them often if I'm going to start patients on continued doses of Decadron. Yes, just to protect the stomach, and especially if there's some prior history of reflux.
Okay. But for protection purposes, it's like if you're using Decadron or something else. Okay. Thank you.
Welcome. Always good to see it go green. There we are.
I have a question about the BAD drip, since you don't want to call it bad. like if we hypothesize or at least consider that probably the Decadron is the most like effective drug in that cocktail. As far as intermittent dosing versus drip, like I always feel like simplifying the regimen, right, or the process in which these patients are getting their medications is ideal. And so I guess with Decadron's duration of action and things like that, do we think we're gaining that much by doing it in the drip? You know, when you say these continuous drips, I'm
Right.
just like curious.
Great question. So the question I'm hearing is knowing Decadron's efficacy given orally and its half-life.
Right.
What is the benefit of doing a continuous infusion with Decadron? And I don't have a good answer for you on that one. And again, we bump into how much of this is psychological.
Sure.
I've got a needle in my arm.
Oh, for sure.
Getting some medication coming through here that must be more effective than
Yeah.
the pill I've been taking.
Yeah. It's like the saline.
I would probably feel that way.
I know,
Yeah.
right.
Oh, my doctor's getting really serious about me now and giving this thing. And especially when that doctor also says to me, genuinely and with confidence, this is one of the things that most close to magic that I do because I am confident in it. Well, there's all of this kind of interplay there.
Okay.
We see our oncologists dose Decadron at high doses at 4 times a day.
Yeah.
And that's not common for me. Typically, if I'm dosing Decadron, I may dose it once a day or twice a day.
Right.
But you can certainly dose it orally, doses higher. So
Yeah.
from a medical standpoint, I would have a hard time describing for you why a continuous infusion of Decadron
Yeah.
is any more effective than oral dosing of.
Yeah, or even, you know, if you were to do a subcutaneous administration, even if it was intermittent, as opposed to a drip.
Oh,
You know what I
right.
mean? Like give them the dose, even if it's multiple times a day via that rather than setting up a drip. I don't know if some of this is.
A drip's going to be just easier.
That's what I was wondering.
At a home situation, which having anybody put.
I was here last month, so like
Yeah.
with nurses and sub-Q administration, we actually avoid the drips here at Trillium.
You do?
Not avoid them, but I had not experienced any of them because we've been able to, you know, you have a nurse to administer
Oh,
the
really?
intermittent dosing, yeah.
Oh,
So
okay.
over the month I was here, I wasn't aware of anybody on a drip, but everyone had sub-Q buttons. So that's why I'm asking.
So an inpatient hospice unit is probably the only environment where you're going to run into that, where you
This
have.
is, hey, Todd, this is Fitz.
That's,
That was an anomaly. We use
Oh.
pumps and infusions all the time. You just had an easy month.
Sorry, Fitz. I was just,
Even with the.
I was surprised too. Anyways, okay, my bad. I didn't mean to say we didn't do them. I just meant like I didn't experience them, so.
the voice from the computer speaks.
I know. I'm like, sorry. But I could see at home that it would actually be easier to have a drip because it's sort of like
Yeah.
computerized and like as opposed
So-
to someone administering.
Yeah, none of my nursing staff are going to want to do
Right,
bolus dosing of anything.
okay,
And this is always interesting to me too, though, because I knew nothing about subcutaneous infusions in my medical career at all until I started doing this fellowship. But it's puzzling to me why we don't use these in the hospital,
or the pre-hospital setting.
right?
Like, why are
But we don't. We don't. My father was a veterinarian. Dad used subcutaneous. Now, dogs and cats are different than humans. They
Yeah.
have a lot more space under their skin.
They're back of their neck.
He would give a whole bunch of fluids just under the skin and be very effective at.
I looked into this a couple of years ago. And a lot of it has to do with the dosing, the flow rate and the pumps that they're using, at least in the hospital.
Okay.
So it'd have to be a whole system change of sorts, because I tried.
But even
Did you try?
I tried.
even
These are third world countries
Uh-huh.
where it's so easy to place a subcutaneous line. And the challenges with it are, I mean, you don't want to give anything that's, going to extravasate, and then you're going to have irritation, I suppose. But so there are some downsides to it. But anyway,
But pre-hospital, I still don't understand why, even as an initiated dose for pain control,
right,
sub-Q, and then work on an IV,
right.
after they're controlled.
Yeah.
Like, it just seems like that would be a great application.
I'm impressed that you tried, Joel.
Well, so what I'm hearing you say is that if a pump could be made for sub-Q administration, it would be more feasible.
And I would say pumps are made for it because we're doing it.
Yeah.
We have
all the
them.
time. It's,
They exist.
Pumps are here in this, and we do them in the home setting.
Can't you just adjust the settings or is it
No.
that, not that?
to get things low enough or something
Oh.
along those lines. So I think maybe if we pushed and said, we're gonna put all our palliative patients on sub-Q, we may get some more leverage and be able to do something that way. But for the amount of people, most of the times when they're in the hospital already, by the time palliative sees them, they've got an IV.
Right, that's the key. Yeah, I was like, because you probably wouldn't choose, if you had IV access, it's not like you would prefer subcutaneous.
Not unless
In the
they're going home.
Right, but I mean, like in the inpatient
And
setting,
even like, I'd love to do it for our GIP patients. If they're gonna be with us for a couple days, gotta change out the IV,
Oh,
why
right.
not put in a sub-Q?
right.
Yeah, that's Rob. In the nursing, we do use sub-Q fluids occasionally, hypodermoclysis. The maximum rate is 60 milliliters an hour, so it's fairly slow. But if you calculate how long that takes to put a liter in that way. But occasionally, when you have a high sodium or something like that, and they're not taking in fluids very well, then we'll try a liter of subcutaneous fluids in the nursing home setting. So yeah.
Wonderful. Good.
16 hours. That's a board question too,
60 an
the
hour.
flow rate.
Oh, 60.
Yeah,
No, but 60 cc's is the maximum.
Rob, have you done bad infusions in the nursing home setting, the long-term care setting?
Not entertain that thought, but that is an interesting thought. I wouldn't think that there's any reason why we couldn't do something like that. Yep.
I would agree. I mean, the staff there are trained already and appropriate. I think the times when I've run into it is we've not done any prep work to get the staff in the facility on board with that. And so then I've got a patient that I'd like to do it on, but we don't have any process in place to do it. So we've just been hit with, no, you can't do that. But I suspect that if we got a little more proactive with some of our facilities, that we probably could. To be honest, I don't have to do it all that often these days. So I guess my motivation for doing the prep work with the different nursing facilities is probably low. But now
It's fits here. The issue in the nursing homes, and Rob can speak to this, is whether an RN can manage the pump or an LPN, and staffing then becomes the issue for them.
Very true. Yep. Thanks, Fitz.
But then we've got family members doing it at home.
I know, that's what I mean. No, that's interesting
Yeah,
that we let families do it at home.
yeah.
I was just gonna speak up a couple things about that. Like one, you mentioned about one of you about giving intermittent boluses of Decadron. I think it's just hard in the home setting. I think that's why those infusions, as Todd said, is so helpful because it's just easy. We just can't have a nurse even every day. Sometimes we do give those boluses of Decadron. I guess the main thing, I agree, it works and it's magical. I'm not sure why. I just think just for everyone taking board exams, it is not on the boards. It's not going to be a question that I know of. And if anyone has seen it, please let me know. So I think just know that there are some things that we've learned by experience that are based on evidence and will be on boards, and there's things that are not. And I just want to make sure our fellows or people taking boards know that. But I do agree, when nothing else is working, it does seem to work. So the other thing, the random thing I found that was helpful with the subcutaneous button it was a patient with inpatient, maybe they're transitioning to comfort care, combative getting out of bed, and the nurses were afraid to put an IV in. They could have hold down and put, IM injection, but what they ended up doing is getting a sub-Q button and putting it somewhere around the back where we couldn't reach it. And then that way we could start with some subcutaneous meds, benzos, maybe phenobarb, different things, and it really helps. So I always keep that as a option in my mind. We could use it inpatient and in certain settings like that.
And I would think also
Thanks,
Gretchen, for pediatrics, like of sub-Q for pediatrics when IVs are sometimes even more difficult, like in our oncology patients over at DeVos. I mean, I realize eventually an IV is gotten, but there's got to be times where they lose access, but are pretty symptomatic.
Sure. And Kiva had a question. I don't know if I have the answer. Could you use the infusion pumps from the NICU for sub-Q infusions?
Oh, just because they're low volume.
Yeah.
They actually put the syringe on those on the NICU because it's such low volume.
We're now well outside my area of expertise.
Yeah, I don't know the answer.
I know the answer to that
Teach people.
Honestly, we don't use sub-Q a ton in pediatrics. I don't really know the reason for that. It's probably just, habits and practice.
Yeah.
I guess, but there's no reason you couldn't use the amounts of medications we're giving over these pumps, even on the regular floor and not just in the NICU, are very small often. And so the PCAs have settings that can go down quite low, where you're like, are they even getting anything? But for their size, it's appropriate, obviously.
Just a bit.
But yeah, I'm sure we could use sub-Q much more frequently than we do.
Yeah, it was like the thing they just need to get like exposure to.
Probably.
And then Dr. Van Alstyne also says, article out of Ann Arbor, possibly Dr. Marks, indicating more than 8 milligrams of Decadron does not add benefit to and does increase side effects. So may want to keep within that 8 milligram mark.
8 milligrams a day.
For nausea.
Yeah, is that per day, Fred? We'll clarify when we.
8 milligrams of added.
Of Decadron. So I'm not familiar with that article, Fred, but I would say from my experience, that's been true. I think when we see patients coming to us on the really high doses from oncology or from the neurosurgeons, I think the Decadron is being utilized for some different purposes in those situations. From a symptom management standpoint, particularly I would say with nausea and with appetite stimulation, it's rare for me to go above 8 milligrams a day. It's even rare for me to do 8 milligrams a day. I suppose once in a while I'll do 4 milligrams twice a day, but that's pretty much been my ceiling anyway.
Sorry, it took me a while to figure out how to unmute. 8 milligrams a day was the upper limit of what they were suggesting. It was an article with several authors and a pharmacologist maybe a couple, 3 years ago. And it was Adam Marks and et al.
Okay.
Oh.
Thank you.
I'm sorry, I have just one more question. I feel like Zofran is our go-to for a lot of nausea, vomiting symptoms. Side effects as far as constipation and headaches, which I don't think is talked about enough. And number 2 is the occasional patient that has a paradoxical reaction, meaning it causes increased nausea. Do you guys see much of that?
Rare.
I'd say you're looking at me like.
I didn't know that.
I have rarely run into those types of challenges with Zofran. Yeah.
Okay.
Tends to be tolerated pretty well. So.
Well, it's 7:35.
By the way, Joel, quirky side effect of Decadron is hiccups.
Hiccups.
It doesn't happen very often, but
Decadron doors, exactly.
definite association with Decadron and inducing hiccups in the subset of people.
Yeah, so I think we can develop a DT drip thing.
A lecture on hiccups would be so fascinating, because talk about an orchestral sort of a situation. I don't think anybody has a great, clear sense of hiccups, just they're so multifactorial. And then the things that you can do for them are we had some email strand that was going on a decade ago about different things to use for hiccups, and oh my God. So
The definitive cure is holding your breath for 15 minutes.
That will do it.
All bleeding stops.
Yep. Yeah.